My name is Tim Clay, and I'm a medical oncologist from St John of God Subiaco Hospital in Perth, Western Australia. On behalf of my co-authors, our trials teams, and the sponsors, I am pleased to present updated results from the TACTI-002 trial. Current treatment for non-small cell lung cancer in the absence of an oncogene driver is based around an immunotherapy backbone, either given alone or in combination with chemotherapy. Some patients obtain impressive and lasting benefits from immunotherapy, and its use in non-small cell lung cancer has seen a jump in the long-term survival outcomes for our patient cohort. Despite this, many patients have cancers that either fail to respond to immunotherapy or progress down the track after an initial response. As a result, novel approaches are required to circumvent primary and acquired resistance to immunotherapy. Eftilagimod alpha, hereafter referred to as EFTI, combines the extracellular portion of human LAG3 with the Fc fraction of human IgG1. EFTI binds to MHC class II receptors on the surface of antigen-presenting cells, increasing their activation and improving presentation of tumour antigens. When successful, this strategy leads to a sustained anti-tumour cytotoxic T-cell response. In Part A of this study, patients with treatment-naive non-small cell lung cancer in the absence of EGFR mutations or ALK gene rearrangements were treated with pembrolizumab and EFTI. EFTI is administered subcutaneously, initially fortnightly for the first 6 months, and then 3 weekly for a further 6 months, up to 1 year of treatment. Pembrolizumab was administered intravenously at a flat dose of 200 milligrams every 3 weeks for up to 35 cycles. In our study, the primary endpoint was response rate by iRECIST. In this paper, data cutoff for the cohort was the 16th of April this year. EFTI and pembrolizumab in combination have previously been demonstrated to have a favourable safety profile with a similar toxicity rate to single-agent pembrolizumab. In this study, grade 3 toxicities were uncommon. Grade 3 or higher treatment-related adverse events were noted in 5 patients. No fatal events seen in this study were adjudicated to be due to the study combination. 6 patients, or 11.5%, discontinued their treatment due to toxicity. Our cohort was broadly representative of a non-small cell lung cancer population. The median age was 68, and almost 70% of subjects were male. 94% of study subjects had a current or prior history of tobacco use, and 58% had non-squamous histology. Overall response rate, the primary endpoint in our study, was 36% by local assessment and 41.7% by blinded central review. On blinded review, a complete response was obtained for 2 study subjects and a partial response was seen in 13 study subjects. The disease control rate for the whole cohort was 66%. The waterfall plot is seen on the bottom left of this slide. Of note, in this study, responses were seen across the spectrum of PD-L1 immunohistochemical staining. The median progression-free survival for the entire cohort was 8.2 months. Amongst study subjects who achieved an iRECIST response, 58% of responses were maintained beyond 6 months. At the time of data cutoff, 7 patients remained on therapy, and 1 patient has completed the 2 years of treatment and is now in observation. The median duration of response to this treatment is estimated to be over 12 months and will be reported after further follow-up. In conclusion, the combination of pembrolizumab and eftilagimod alpha remains well tolerated and has a favourable safety profile. The combination has encouraging efficacy in this first-line treatment setting with a 41.7% response rate and a median PFS of 8.2 months. As a result of the early favourable data in this report, the cohort is being expanded to gather more information on this combination. As always, we wish to thank the patients and their families and friends for their invaluable contributions to this research.